Thanks so much, Jane, and thanks very much for the introduction. Hello, everyone. It's really great to be here with you this morning. As Jane has said, myself and my colleague, you can see Carolyn on screen there, Dr. Carolyn Blair, are going to be joining you this morning. So we're here today to talk about a recently completed NIHR project which focused on integrated oncology and palliative care. To talk through the research itself, some of the key findings, and then also Carolyn is going to speak specifically about recommendations for policy and practice. I'm just going to move on to our first slide here, because one of the things I want to point out in this slide is the QR code. So this is the QR code for our research website, and I would really encourage you, if you have time, to access that. You can see a full overview of the research, the team members, the published protocol, the full publications of the findings will be there, and there's also blogs that have happened throughout the research process. So please do, if you have time, access the QR code and visit the research website. So Carmen and myself were not the only team members on this project. We had a variety of colleagues, both from within Queen's University Belfast and also within the University of Oxford. And you can see the team members on screen here in front of you. When I was first writing this grant and thinking about colleagues that we wanted to work on it, it was really important to get a really good mixture of both subject but also methodological expertise for the project. So that's really the range that you see across here from, for example, Fiona Lynn, who specialises in economics, to Jeff Wong, who many people will know is the expert in terms of realist synthesis, realist evaluation, realist methods. Right through then to, because this is a review of the literature, a search specialist, and that was Nia, who you see here on screen. One thing I just do also want to point out from this page is Elspeth Banks. You can see Elspeth on the screen here in front of you. Elspeth had worked with myself at NCRI for a number of years in their very now disbanded special interest groups. Elspeth worked with us as a patient public involvement and engagement representative, a PPIE representative, and that's how I had worked with Elspeth before. But Elspeth was one of our core research team members. She was a co-applicant in this grant with us as well, actually. And reflective of Elspeth's really in-depth engagement with this, she was fully costed into the grant as a research team member. And that really underpins Elspeth's active involvement. She was present at all research team meetings that happened on a monthly basis. She reviewed with all the other team members every stage of the application going in through to the project paperwork as we moved through the 18 months of this project. So it was great. Actually, that's the first time we've worked with a co-applicant at that level of engagement in this project, and it was a real strength to the project. I would really advocate for that within future projects, I do have to say. So just to give you a little bit of information about the background to this particular area, and internationally, as many will know on the call, cancer is a major public health and also economic issue. And we have a growing number of people, and expected that to be larger growing number, who are both living with and being treated for cancer. There have been a number of randomised controlled trials that have looked at the integration of oncology and palliative care, and they do point to health gains. So things like improved survival, improved symptom control, less anxiety, less depression, reduced use of futile treatments, particularly chemotherapy at end of life, improved then satisfaction for not only patients but also for their family members, and also improved quality of life for family members, and also improved use of resources, healthcare resources. But despite that growing body of information and knowledge, and also key organisations, so for example, European Society of Medical Oncology, who strongly endorse the integration of oncology and palliative care, it is still not commonplace. And actually a consensus on what constitutes integration, whenever we're talking about integration of oncology and palliative care, is still not agreed, finalised, it's still lacking. So there is a requirement to better understand what integration entails and how it is optimised. So this project really focused on that. It was trying to understand how integrated palliative care in cancer care works across different healthcare settings, For what groups of people, both patients, family members, and also taking into account different healthcare professionals, and at what stages of the cancer journey. And what we really wanted to do was pull all of this information together so that we could see what works for whom and in what circumstances to help inform delivery. So in terms of the methods then, this was a realist review, a realist literature review. And a realist review is slightly different from a narrative review or different types of literature reviews, an integrative review. A realist review really unpicks what works. It seeks out those explanations of why did this work, or what hindered this working is the other side of that. So what works or what doesn't work? How does that work or why? And then for whom and in what circumstances? So there's only so much information that you can get from the literature. So one of the things that we did around this project then was that we also set up an international key stakeholder group, and I'll show you that in the next slide. And the role of that international expert stakeholder group was really to help uncover some of the explanations for what we had uncovered within the literature, to say, how does this work within clinical practice from the perspective of patients, carers, or healthcare professionals, or commissioners of service. And the aim of that was to really understand and to give some depth to what we were finding within the literature, to help understand how integrated palliative care within oncology works. So we wanted to use that then to aid the understanding, to develop guidance. And one of the things that we're going to show a little bit later on is some of that guidance in a findings animation, and we'll share that with you. So this is an overview of our expert stakeholder group. So it's made up, as you can see, of, and we were very strategic in relation to this, it's made up of various different categories of people that we wanted to really help inform this realist review. So we had members from NHS management and leadership, both oncology and palliative care, healthcare professionals involved in the delivery of both palliative care and cancer care, and we really wanted to ensure with multidisciplinary team members within that. Also then national and international research clinicians in palliative care and cancer to think about transferability of some of what we were finding into a broader population. Policy and community groups as well then we wanted to include, so that we had sight not only of policy but also of what informs commissioning. Alongside these people then within our stakeholder groups, we also had additional patient and public involvement partners. So these were again a key facet of our stakeholder groups. And these 4 members of our PPIE representatives joined each of the key stakeholder groups. So it was really important for us that whenever Elspeth, Peter, Carrie and Sharon joined the meetings, that they felt really part of the meetings. And we have worked with PPIE partners before, and sometimes it's difficult for them to find their voice, particularly whenever they're in a large discussion room that's being facilitated online, and they're there with very senior healthcare professionals who are working with them within these groups. So what we did with our PPIE partners was, prior to each meeting that we had, each key stakeholder meeting, we would have met with our 4 PPIE partners and went through the slides that we were going to cover and went through the topics for discussion that we were going to cover at the stakeholder meetings, so that they had an opportunity to ask any questions, to seek any further explanations, if they wanted to talk through some of their responses with us prior to the meetings, so that they felt confident and comfortable within the meetings to do that. They had an opportunity to do that. So each of our stakeholder meetings was about 2 hours long, and about the week then prior to that, we'd have met with our 4 PPIE partners, spent a good hour with them going through the slides, points that they wanted to bring through for discussion, to make sure that they could articulate those within the meeting, so that they were very active participants within the key stakeholder groups. And that worked very well for us, because in actual fact within our stakeholder meetings quite often it was our PPIE partners who led the discussion. So it was lovely to see them really bringing their voice forward. So what did we do with our PPI and our stakeholder groups? Well, as you can see from the previous slides that I've showed you and on screen here, we had about 17, 18 members of our key stakeholder groups and also PPI representatives who joined each of our stakeholder meetings. So across the duration of this 18-month project, we had 5 key stakeholder meetings, and they were ran at very specific points within the project where we wanted input and feedback. So whenever we were conducting the searches, were there additional papers that they felt were very important to be included within the narrative review? Whenever it came to looking at the results and interpreting some of the results, there were key points that we wanted to bring forward for discussion and explanation for the groups. Whenever we were thinking about how we put the findings together and recommendations for practice and policy, again, they were asked to contribute at those points. So they very specifically fed into key aspects of the project right throughout the 18 months that the project ran. So what did we do with our searches and how did we bring this all together? So a search specialist, Nia Wynne, who I showed you in the third slide undertook the initial searches. So these were done in June 2023. Nia set the searches up and we then undertook the screening here within Queen's. There were monthly searches then, there was search alerts that were set up, monthly searches that were set up right through to completion in December, and our key stakeholders then also fed in key papers to look at that as well. So in total, as you can see, as we move down through this from the numbers that were screened right through to searches, stakeholder papers, hand searching of journals, and as we worked down through the screening, then we included 164 articles altogether within this particular review. So in bringing those all together then, this is really an overview of the main results that I'm going to talk through here, and then we're going to share part of an animation to show you that as well. So the main findings that we're going to talk through here, you can see those on screen in the figure in front of you, and just to talk through this diagram then from the top, and we'll work our way around this circle. So firstly, understanding what needs to be done in palliative care. The literature, I think, really highlighted society's perceptions of palliative care and also understanding what palliative care is and what palliative care is not, that there's a degree of misunderstanding that's still present there. That's not only within the public, that's also across healthcare professionals. So it is really important, therefore, that all healthcare professionals are equipped to be able to explain what palliative care is and what palliative care is not. So, for example, it's not only applicable at end of life, to patients and their families, so that there's consistent messaging and correct messaging in relation to palliative care provision. Alongside that education then, there is a need for media and also public health campaigns to address much more widespread misconceptions around palliative care. In terms of involving people in the work, what we did find from the literature was that integration was much more likely whenever leaders demonstrated that they had prioritised palliative care within their organisations. Change champions, where staff can advocate for integration and also support their other colleagues, were key in terms of implementation success. And implementation shouldn't just be about 1 or 2 people, it should be about informing and involving relevant clinicians. And what is important to understand is where there are areas of resistance, that those are identified and understood so that they can be resolved. Sorry, Jane, I'm not sure if that's me or you. In terms of working together, it's really important that roles and responsibilities are clear across both palliative care and oncology teams, that there's regular opportunities for regular communication between professionals, and that communication has a respectful collaboration that really encourages teams to share their perspectives and involves the coordination of care planning and scheduling. And also then provides opportunities for specialist staff to share their expertise, opportunities for learning, to support staff in skills and confidence. The outcome of this then is really in terms of delivery of timely and also tailored patient-centred care. And central to that is how we identify people who have palliative care needs, and also then providing an early introduction to palliative care as part of care delivery, as part of the care team, so that it's normalised as something that you can opt into when you need it and you can opt out of it when you don't need it. And central to that is information on what to expect as part of the illness journey and what services are there to help support that. And that's really around empowering patients so that they can be involved in shared decision making in relation to their care. So in terms of then considering how well it's working and realising and recognising the benefits, the literature really, I think, highlighted the fact that a holistic needs-based approach to care rather than a prognostic approach to care can really help to better understand realistic scenarios and also include patients and their family members' preferences around care. Working together so that those known patient preferences can also, I think, lead to less moral distress for staff, which was something that really came through within the literature when there was differences between patients and healthcare professionals in terms of perspectives of best care, or also between healthcare professionals in terms of a selected route of care, that moral distress could be experienced if there wasn't that shared decision making. But in terms of evaluating integration of palliative care within oncology, what was really important was that how it's evaluated is really important, and there may be different metrics that are appropriate for patients and for family members, and then for healthcare professionals and care commissioners. So how early integration of palliative care is evaluated is really important so that it helps collect the correct data to inform those relevant parties. So, as I mentioned, we've taken all of those findings together, which was a very large document in and of itself. And what we wanted to do then was work very closely with our stakeholder group, so within the research team and also our stakeholder group, to be able to develop an animation in relation to integration of palliative care in oncology. So this is an animation that is free to use and free to download, and that's really part of the purpose of this. It was developed so that it's applicable across any population, right through from senior healthcare professionals to the public. And it's pitched at that level so that it can really be used for education purposes, for dissemination purposes. You can access it through the QR code, which you can see on the top right-hand side of the screen here. And it's also hosted on the All Ireland Institute of Hospice and Palliative Care YouTube page. So Claire is going to play it for us here, just so that you can see the animation of the findings.
We carried out this research to improve care for people with cancer through bringing together cancer treatment and palliative care. When people get a cancer diagnosis, it can be a scary time. There have been huge advances in cancer treatment, which is to be celebrated. As a part of supporting the person with cancer, we can offer palliative care. Palliative care looks at a person's physical, psychological, social, and spiritual needs at all stages of a serious illness, not just for end-of-life care. Providing early, integrated palliative care can improve quality of life by helping with symptoms such as anxiety, pain, tiredness, and loss of appetite. Even though we know that integrated palliative care in oncology is beneficial for people with cancer and their families, it is still not happening everywhere for everyone who needs it. Our research shows that we need to have accurate understandings of what palliative care does and does not involve, leadership support and champions for palliative care, professionals who are clear in their responsibilities to provide palliative care, effective communication and collaboration between professionals, ways to evaluate integrated palliative care in cancer and share best practice, Enabling and supporting all healthcare professionals to understand the modern definition and purpose of palliative care would equip them to be confident, explaining the goals of palliative care to people who have cancer and their families. Public health campaigns and organisational messaging could communicate the benefits of palliative care to achieve more widespread understanding and acceptance. Integrating palliative care in oncology means everyone who cares for the person with cancer working together, respecting each other, and sharing their expertise. The professionals involved need to be clear on their responsibilities, which might require guidelines detailing the palliative care responsibilities of healthcare professionals who are not palliative care specialists, such as GPs and district nurses. Effective, regular communication and information sharing is essential in supporting teams to work together to plan and deliver care. By working together more frequently and collaboratively, healthcare professionals can learn skills from each other and become a confident and effective team. Role models or champions within disciplines can help support their colleagues to work in new, more integrated ways. Integrating palliative care in oncology can improve quality of life for people with cancer and provide a more positive working environment for staff. Tracking progress and sharing local examples of good integrated care makes these benefits more obvious to people involved. As part of integrating palliative care in oncology, we need approaches to identify people who need palliative care or who may need it soon, as well as information and support for people with cancer and their families, so that they can be more involved in decision-making about their care and feel safely cared for out of hospital. Palliative care for people with cancer should be based on their needs, not their prognosis. If we make sustained efforts to weave these strands together, we could improve the lives of people with cancer and their families.
Hopefully you'll agree that Nathan Conn, our designer and our animator, did an excellent job in producing this. There we go. That's us now. So as you'll have grasped from Joanne's overview diagram, we've formulated 4 areas for our recommendations. 1, understanding what needs to be done. 2, involving people in the work. 3, working together and becoming a team. And 4, considering how well it's working. So this is essentially what the next 4 slides speak to. And as Joanna said, that firstly, we formulated these into context, mechanism, outcome configurations, these CMOCs. And then with our research team and our stakeholder group, we move towards formulating these into more specific recommendations. So firstly, understanding what needs to be done, and this is really focused on developing a sense of coherence as to the logic to integrating palliative care into oncology management. So what we're suggesting is that education providers, for example, universities, royal colleges, including organisations overseeing CPD, they should integrate palliative care training and experiential learning with their education curriculum and professional development, provide professional development for health and social care professionals. What we're recommending is that funders and commissioners of relevant government departments and clinical commissioning groups and integrated care boards provide appropriate funding routes and resources to facilitate integrated education opportunities. So essentially bringing palliative care and oncology together. So further recommendations are focused on academic research institutions, public health research agencies, large research funders, for example, NIHR, the Health Foundation, helping organisation and system leaders to become more aware of the benefits of integrating palliative care. Joanna's obviously spoken to this, but obviously, for example, this is by providing evidence of high value care and return on investment as well. We also are recommending that organisation and system leaders, and thinking really here about NHS leadership, NHS trust executives, integrated care systems, the leads for that should take actions that promote the integration of palliative care. For example, considering how funding and incentives, performance indicators and training opportunities could be aligned to prioritise integration. We're also recommending that organisation and professional leaders, and here we're thinking about professional bodies, for example, the Royal College of General Practitioners, the Royal Pharmaceutical College, and Allied Health Professions Federation, and also national health bodies, that they work to provide clarity on professional responsibilities for palliative care, including detail on the role of non-specialists across different care settings, and thinking here about the likes of GPs and primary care, community care and secondary care. For example, possibly by developing guidelines and supporting the implementation of these guidelines. And finally here, we're recommending that public health agencies, and here we're thinking about our public health bodies, Public Health England, devolved public health departments, government health ministries, and relevant communication partnerships should research and invest in public health campaigns and or media to support more widespread understanding of the benefits of early integration of palliative care. Just essentially what is in it for you and your family, getting that message across. So moving on to our next slide there. So involving people in the work. So if you just flick on there, Joanne, that's okay. Or Jane, whoever's got it. So involving people in the work, this is essentially focused on cognitive participation, as you'll see in the diagram there. So what do we mean by cognitive participation? When learning, we know that we're more cognitively engaged when we play an active role in our learning journeys. So this is what we are trying to promote through this set of recommendations. So here we're recommending the organisation and professional leaders, for example, the Director of Cancer Services, identifies and supports key individuals who can act as champions for integration. Obviously, Joanne spoke to this a little bit earlier, but this is at different levels of seniority and in different professional groups, including thinking about forward planning in cases of staff turnover. We're also recommending that organisation and professional leaders in NHS trusts, they should plan information and involvement strategies during implementation to actively seek to understand and address the concerns of healthcare professionals involved, and to identify outcomes that would be meaningful to them. So this is obviously all part of getting the team engaged in the process. Oncology and palliative care professionals, organisations and system leaders, for example, the likes of integrated care boards, NHS trusts, integrated and hospital management teams, should also introduce and evaluate approaches to identify palliative care needs more consistently and across different care settings. And finally here, we're recommending that education providers, for example, medical schools, nursing colleges, allied health training programs, and other CPD providers, and also regulatory bodies, the likes of the General Medical Council, the Nursing and Midwifery Council, and other healthcare regulators, should provide training that enables, ideally, all healthcare professionals to be knowledgeable and confident in explaining the goals of palliative care to patients and families. So moving on to working together and becoming a team. So here we're really thinking about the need for collective action. And this occurs when we actively work together to achieve our common objectives. So here we're recommending that regulatory and accreditation bodies, NHS leadership and system level organisations, professional bodies, healthcare employers and universities, essentially across the board, should establish a code of conduct for communication as a core responsibility, including across care settings. Essentially what we've drawn from the literature is that appropriate systems, technology, scheduling, and accountability needs to be in place to ensure key professionals can have effective communication. And we're thinking about respectful discussions here about person-centered care. Furthermore, it's important that service leads enable a collective working environment that encourages a sense of respect and understanding between roles, and thus a team culture of communication. And this could include education or professional development initiatives towards collaboration and advocacy on behalf of the patient. We're also recommending that NHS trusts, alongside professional leaders and third sector healthcare providers, should develop a resource a process that enables the coordination of patient care. So this could potentially include allocating the responsibility to a named person or a team of people with the necessary skills, credibility, and influence to take the lead in coordinating care. So when considering informational needs relating to working together and becoming a team, we recommend that both oncology and palliative care teams actively seek to uncover the changing informational needs of patients and carers on their journey of living with cancer. We're also recommending that information hubs, for example, Macmillan and equality departments within trusts, should develop informative resources for people with cancer and their families, tailoring for different needs, including levels of health literacy and for disadvantaged groups. Also recommending that primary care providers, for example, GPs, nurses and pharmacy, and social workers and AIIHPCs explore the needs of unpaid carers, including those that live alone or in rural or deprived areas, and explicitly support them in their role, including sensitive education and honest guidance on what to expect. We're furthermore recommending that commissioners and NHS trusts need to invest in supporting community care, including out-of-hours services. For example, resource for a 24/7 helpline and a rapid response team. Health and social care professionals should essentially ensure that patients and carers are familiar with this service prior to a crisis. On a broader but a very important note, we're also recommending that health and social care professionals identify and respond to the wider factors that may prevent or threaten safety at home. For example, domestic abuse, neglect, addiction, housing instability. So moving on to our final step, considering how well it's working. This slide speaks to the need for reflexive monitoring. And again, Joanne has spoken to this. This is essentially appraisal work where we assess and we understand the ways in which new practices affect us and others around us. So our recommendations here are that system and organization leaders need to identify appropriate and meaningful ways to measure and evaluate integrated palliative care and oncology, and to provide essential feedback to teams. We're also recommending commissioners, NHS trusts, third sector healthcare providers, research funders, and academic institutions facilitate collaboration between specialist palliative care and generalist palliative care providers, providing support to enable educational, leadership, research, and audit opportunities for the purpose of service evaluation and improvement. For example, formal training here, collaborative meetings, informal learning by doing. So recommending that professional leaders and specialist palliative care should encourage opportunities for reflection, emotional support, and personal peer support between oncology and palliative care team members, which is particularly important when we consider what these healthcare professionals face on a day-to-day basis. And finally, we recommend that health and social care professionals should foster communication about the person with cancer's needs, goals, and preferences, and reflection on the options that are available to them, enabling communication, collaboration, and reflection about holistic needs to routinely inform decision-making, This could help to achieve high value care and indicates palliative care as a normalised part of cancer care. In regards to normalising palliative care as a routine part of cancer care, this is essentially the takeaway message here. These recommendations are underpinned by normalization process theory, which is a sociological theory that focuses on the adoption, implementation, embedding, the integration and sustainment of new innovations. And this is essentially what we would hope could be taken away from today's presentation. So moving on to your next slide, and I'm not going to go through these in depth, but as you'll see here, we have 8 research recommendations. We consulted with our stakeholders to co-produce these final research recommendations, and as I said, I'm not going to necessarily go through them all, but broadly, the top 3 were focused on the need to conduct research into improving modes of communication, to push forward meaningful evaluation strategies, and to improve all stakeholders' understanding of integrated palliative care. So similar to the general recommendations, we consulted with our stakeholders in the formation of these research priorities based on the findings of the included reports, which again, Joanna's spoken to. Then a further meeting was held to confirm the ordering of priority here, and we use an MS form to ensure that all of our stakeholders were able to participate. We asked stakeholders to rank these recommendations in order of what they saw as the most important, to identify if any of them were redundant and whether they felt that we had missed anything that was particularly important. So hopefully it's clear, both from what Joanna said and from these slides as well, that the input from stakeholders throughout this project was of vital importance in producing our findings and recommendations. So moving on to our next slide there. So one of the key outputs from our IPCO project has been our website. Again, Joanna's mentioned this at the start, and to date, there's been approximately 3,000 worldwide visitors to the website. And another plug here, but if you have time, please scan the QR code in the corner, which will bring you essentially straight to the website. And our animation, which you saw earlier, is placed on the website. So as Joanna said, please feel free to share it. And also just to let you know that to ensure optimum accessibility and inclusivity, we worked with translators and our animator, Nathan Kahn, in producing subtitles in Polish, Punjabi, and Urdu. So furthermore, on the website, onto our next slide, the website also features updates in regards to the research, as Joanna said, and more details about the team, and also 8 blogs which have been written by different members of our research team and the PPIE representatives as well. And once again, as Joanna said, as I've mentioned earlier, we want to emphasize how indebted we are to our PPIE partners and all our expert stakeholders for so generously giving of their time to meaningfully commit to this project. And on this note, I'll hand back to Joanne, who will explain a little more about the next steps for IPCO. Thank you.
Thanks so much, Carolyn. At our last key stakeholder meeting, one of the things that we were discussing is, what do we do now that we have these findings, and how can we move this piece of research forward? Because we really see this as being the review that's a first step in helping to inform a programme of research within this area. So what we wanted to do, and what we did at that last stakeholder meeting, was discuss our plans and help refine our plans for the next stage in this programme of work. So what we're aiming to do is to write a further application which aims to test the realist evaluation approach. That's the specific type of approach that we used to help understand not only does integrated palliative care and oncology improve outcomes, but how does it do that, and how does that work well, and what hinders that. So what we want to do is gather primary data in relation to all of those key aspects that help inform that realist approach. The funder that we're targeting for this is the same funder as the realist reviews. That's AIIHR, which is UK based. So we would be collecting primary data then from across the four sites within the UK, England, Northern Ireland, Scotland, Wales. And it's really great that we have collaborations already established in each of those four areas, so that we have partners and local collaborators who will work with us in relation to collecting this information. And essentially what we're going to do is purposefully select sites where we know there is existing successful integrated palliative care within oncology services set up. And what we want to do then is collect data around those services. So that will involve interviews with service providers, will also involve focused observations of service delivery to help refine and also move forward our initial programme theory to develop more detailed guidance that will inform then service delivery. So at the end of that, I suppose it's my job on behalf of both Carolyn and myself to say thank you very much for your company this morning. We really appreciate you giving your time to come along to hear about this project. It's been an absolute pleasure for Carolyn and myself to be here today, and just also to thank Jane and Mary for all their technical support in terms of getting this webinar planned and running it today. Very much look forward to a discussion after this and also to seeing you again within the future. So I'll hand